to everybody who's here. So I am going to try to stick to the 30 minutes, but we'll see how it goes, how many yappuccinos I've had today. So if you're here, you know about some of the DCPAP services, but just a plug. So we do these monthly trainings. Please give us feedback on how we can better meet your needs. So we're putting together our comprehensive list for upcoming trainings. So drop us a line with what you would like to see. And then we can also offer practice-based training. So if there's specific things you want to hear more about, or your practice with like an individualized training, we are happy to do that. And then come visit our office hours, Monday, Tuesday, Thursday, 12 to 2. And then we also run our warm line if you want a consultation from a child psychiatrist, or if you want a resource referral support from the lovely Mindy, then please reach out to us. Oh, yes.
Just to qualify, that's for participating primary care providers.
Yes. Yep. Those are services. So my goal is to give a bird's eye view what I would want primary care clinicians to know about anxiety. I'm going to ground this in development, so do a little bit of what worries look like across childhood, talk a little bit about the diagnostic criteria, some clinical pearls and effective interview techniques, and then treatment recommendations. So I'll start with diagnosis and clinical characteristics. So I do want to normalize worries. Worries are typical. They occur in all of us. So I had some natural worries before this presentation, but I can reassure myself, okay, I've done this before, and I know quite a bit about anxiety, so I can feel pretty confident, reassure myself. They can be appropriate survival responses. So if you evolutionarily were living in a cave and you heard a rustling in the leaves and your only thought was, I just love the rustling of the leaves, the saber-toothed tiger might come and get you. So we occasionally need to be worried to get stuff done to maintain safety. And what I would expect is sort of these hills and valleys where we have an increase in anxiety that rises to meet a challenge, and then it sort of goes down, and then we rise to meet another challenge. And as adults, we're often managing multiple things, which could be anxiety provoking, but hopefully we're not living in a constant state of worry or fear. It should resolve and go back to your normal baseline without being there all the time. So age-appropriate fears. There are fears we would expect kids to have that are developmentally appropriate across the lifespan. So infants have a reflexive startle response. So if there's a loud noise, we're going to see them startle. They will have their stranger danger. As they become toddlers, they will have problems, fears separating from their caregivers. Preschoolers focus more on the monsters under the bed and fears of the dark. So for my kids, I got them, out of their cribs into beds, and then they were, immediately coming into mine saying they were afraid of the dark. And this is adaptive. This is anticipated. They were able to be reassured. Middle childhood, kids focus more on their physical well-being. So am I sick? What's wrong with me? Am I going to die? Natural disasters are big. So storms, tornadoes, and then real world creatures. So I was talking to my kid and she said, would you like to go to Alaska? And I said, I don't know, maybe. And she said, but what if we saw a grizzly bear there? So that's like her first fear about a trip to Alaska. And that's very age appropriate for a school-age child. Adolescence, things become a little more metacognitive. So kids start to worry about their interpersonal relationships. Do they like me? Where do I fit? Am I cool? And then more existential concerns. What's going on in the world? What does it mean? What is it all for? So when I try to separate typical fears, which we expect and anticipate, from what makes an anxiety disorder, I'm looking at how they're showing up. So if the anxiety triggers are typical developmental tasks like making friends or going to school, that makes me concerned, right? Because the anxiety is out of proportion to the stressor. This is something every kid must do. And if that's a challenge, kids are functionally impaired in doing that, that's a concern. And then the clinical presentation is stereotyped. So they have symptoms that are sort of replicated across different kids. And you'll see there's a variety of anxiety symptoms, which we might anticipate, but usually they fall within sort of the same realm. And then often within a specific child, how they show anxiety will show up in the same way. So they might have a friend stress and a school stress that gives them anxiety, and say they're sort of an avoidant, anxious type. they'll be avoidant in both of those situations. So it'll appear in a similar way. So common anxiety symptoms in youth. I have bolded irritability because this is like the panacea of child psychiatry. So we can get irritability in ADHD, in mood disorders, and yes, in anxiety. And so kids very easily become irritable, and that is a way they show distress. And so even though we think of anxiety as sort of this internalizing, this turning inward situation, particularly in adults, in kids especially, they can sort of explode outward, and they can become sort of mean and snippy. And so I always think of this as if I'm driving in traffic and I'm going out for ice cream, I have all the time in the world, and someone cuts me off. It's like, who cares? No big deal. If I am nervous, I am driving to something that's very time sensitive. I have to pick up my kid or they're going to be late and who knows what will happen to them. And then I'm in traffic, someone cuts me off, I'm not going to make the light. I might be irritated. I might, I have a different reaction. And so that sort of irritation, that lack of control is what shows up in kids as well. Avoidance is classic. We procrastinate. We don't want to address the things that make us worried. Rigidity. This is, again, a desire for control when kids feel out of control. They're worried, they're fearful. And so if we can stick to the plan and I can understand the plan and I've figured out how I might confront this and you change it on me, that's going to be very difficult. And so sometimes we'll see kids like follow parents around the house, asking questions repeatedly, needing more reassurance about what they're going to be doing. And it might be sort of like mundane tasks like, well, we were going to go to grandma's house, but now we're going to Uncle Bill's house. They're comfortable at both houses, but the kids are indignant that, this change has been made and they need a lot of sort of preemptive warning and walking through how that will look. Kids might not be able to say, well, that made me really worried. They just might have a tantrum. So just a big emotional response we might see. If especially there's problems with separation, kids might be clingy to caregivers. And then their worries are not going to match up with where they are developmentally. So if I have an adolescent who's afraid of the dark, that gives me pause. Similarly, if I have a school-age kid who's filled with existential dread, that gives me pause as well. If they're like, oh, just the state of the world and I don't know, and everything feels that's concerning to me in sort of like a 7-year-old or something like that. Physical symptoms are anticipated, especially in kids with anxiety, even more than in adults. Stomach aches, headaches, sweatiness, palpitations, chest tightness, dizziness, chills, and muscle tightness. Muscle tightness is actually in the criteria for generalized anxiety, you'll see. Physical symptoms are common. I'm sure you see them every day in your practice. So these are the main anxiety disorders. I'm going to focus on the big three: generalized, separation, and social anxiety. The bottom three I'll just touch on here so you're aware. Panic disorder, I will talk about in the context of panic attacks, but it's basically anxiety about having a panic attack. Specific phobia is exactly as described. This is actually the most common anxiety disorder. So a phobia about something specific, arachnophobia or fear of spiders would be a good example. And then selective mutism is kids who selectively don't speak in situations, though they have the ability to speak. Selective mutism is probably worthy of its own talk because it's just a little bit different. It has an association with communication disorders and is predictive of later development of social anxiety. All right, so I'm going to go through the criteria for our big three. Generalized anxiety. I do think that because we feel anxiety in the room, often, even I do this, I get a little cavalier in diagnosing anxiety. I'm like, oh gosh, they were just so anxious. Obviously, they have anxiety, but it is really worth it to look at the criteria. So you need this excessive anxiety and worry most days for at least 6 months about a number of different things to meet criteria for generalized anxiety. So it is quite a significant time course. Difficult to control worry. And then in adults, you need 3 or more of the associated symptoms. In kids, you only need 1. Restlessness, being easily fatigued, difficulty concentrating, irritability, muscle tension, which I mentioned, and sleep disturbance. And then it has to cause clinically significant impact in your functioning. So it has to show up. It's not just cognitively, I'm worried about things. It has to somehow cause distress or impairment. And it can't be due to a substance or a medical condition. I think when people come to me and they say, oh, I'm just so anxious, and I'm not thinking that they're anxious, what's usually missing is that functional impairment. So like I said, it's normal to have worries, but if you worry a few times a day about various things and you move along and meet the challenge without dropping the ball in any way or without having such distress that you sort of freeze up, it's unlikely to meet the anxiety disorder diagnosis. So here's a typical presentation. We have an 11-year-old who's coming in. He's not doing well in school and the parents are concerned. He's had several months of daily stomach and headaches. He's missed school days. He's having problems falling asleep. He's very irritable. When you ask him about his mood, he said, well, I am sad. I'll be sad for like a day. I cry, but it doesn't persist. He's not sad for weeks on end. He says, I'm really just sort of hopeless. I'm always thinking something bad will happen. Parents are very focused on worries. He worries about everything, whether they'll get divorced. They say, we don't have any problems. We're not sure where he's getting that, their finances, and then what school friends will think. They describe him as very rigid and uptight. They're saying, we are all walking on eggshells. We don't want to upset him or set him off. As a younger kid, he had problems with separation and school drop-off. So what I like about this case is it shows symptoms sort of across a few different domains. So he's having physical symptoms. He's irritable. He has the insomnia, so he would meet criteria. And then he also has sadness and crying, but you're able to rule out depression because he doesn't meet the 2-week threshold needed. So really, depression should be episodic, whereas anxiety is going to have more of a chronic feel. He's worrying about everything, and then he's sort of almost explosive. And so sometimes people will get sent to me and they're like, oh, he's having explosive outbursts and he's sad. It's probably a mood disorder. When you really get into it, there's just this undercurrent of worries that are leading to these episodes. And then historically, he had earlier problems with separation. Often we'll see that as kids who develop more significant anxiety later on, is that separation was a problem earlier. All right, moving on to separation. So this is anxiety about separating from caregivers. And it shows up in some sort of unique ways. So you have distress when anticipating separation. You also worry about family dying. This can be very distressing to parents. So they will constantly ruminate, like, I think you're going to die if you go to the grocery store. And then worrying about something happening to them. So I'm going to get lost, or I'm going to be kidnapped, or maybe I will die. And then not wanting to go out, not wanting to be alone. And that can even include within the house. So I will have kids who the parents will say, okay, go upstairs and do your homework. And they're like, you're going to have to come upstairs with me. I'm not going to be up there by myself. And so then they're doing the homework only at the kitchen table when everyone's around. They really don't want to be alone at all, not just at nighttime. And then not wanting to do sleepovers, nightmares about separation. And this shows how important physical symptoms are in childhood anxiety. The complaints of physical symptoms are written into this disorder. So headaches, stomach aches when separation occurs or is anticipated. Has to be at least 4 weeks. In kids, longer in adults, and then again, the clinically significant distress or impairment must occur. Okay, and moving on to social anxiety. So social anxiety is a little bit unique. This is another one where people come to me and say, oh, I had a negative experience with a friend.
Her with these other kids and no one is doing anything about it.
Just make sure everybody's muted.
Who's our teacher?
I'm gonna mute you. Okay. So social anxiety. Kids will come in and say, oh, I think I have social anxiety. I get so worried when, I talk to friends, and it'll sort of happen sporadically. It won't be consistent. And so the focus of social anxiety disorder is the evaluation of others. So fearing that other people are going to negatively evaluate or humiliate you. This can happen not just in social interactions, but also in other ways. So sometimes I'll have kids present and they're having weight loss. The family says, they're eating fine at home. The kid denies eating disorder symptoms. And what comes out is that they don't want to eat at school because they don't want people to observe them eat. Same thing with the bathroom. So sometimes I'll have kids that have sort of unusual eating behaviors, but it's because they don't want to have to poop at school. So I'm always screening for that, like any problems going to the bathroom, any problems eating at school or in front of other people. Performance anxiety is part of this too. So performing in front of others, giving a speech would be part of social anxiety. In kids, it has to occur in peer settings, not just when you're interacting with adults. And kids might not say, I am fearful. They might cry or have tantrums. And the fear has to be out of proportion to the threat. So if a kid is being bullied and another child is actually being quite mean to them, it might be reasonable that they would be fearful or avoidant. And so that doesn't count. And then it has to be persistent over a long time. And that's where I think most people that believe they have social anxiety are sort of missing things, that it has to be 6 months or more, causing clinically significant distress or impairment. And it can't be due to substance or medical conditions like all of these. So some notes on panic attacks. So a panic attack is an abrupt surge of fear. It peaks within minutes. So people will say, oh, I had a 2-hour-long panic attack. It's like, well, we had a 2-hour-long increase in anxiety, but the actual panic itself will not persist that long. And so I think that is key. And that's key when I'm counseling people about use of as needed medications and things like that. So symptoms include all the physical symptoms we've talked about for anxiety, but also some unique cognitive symptoms. So sometimes we'll get dissociation, which is a disconnect from reality where there's concerns, am I real? Are the things around me real? A classic would be you're involved in a very stressful or traumatic situation, like you're in a motor vehicle collision and you're being extricated from the car and you're looking down at yourself as if from above, you're having an out-of-body experience. So this can happen in a panic attack. There might also be a fear you're out of control, you've lost control, or even that you're dying. And so the classic is you feel as if you're dying, you go to the emergency room. Panic attacks are a symptom. They are not a disorder themselves. So these can occur in any anxiety disorder, or even, if you had a really stressful event outside of a disorder. Panic disorder itself requires a specific change of behavior related to fear of having or provoking a panic attack. So agoraphobia would be staying inside, saying, oh, if I go outside, I'm going to have a panic attack, and so I must stay inside. Looking at the epidemiology of anxiety, so it's about 7% of youth worldwide. It's even higher in the US, and the cumulative prevalence is higher, so like up to 20%. Some of the earliest psychiatric conditions to emerge, so the mean age of onset is 11 years. The disorders we see correlates with age-appropriate worries developmentally. So preschool, we see separation anxiety start to emerge. School-age kids, we see a lot of specific phobias. So that was the age, remember, where we're thinking about real-world monsters and natural disasters. So they might be phobic about storms or spiders, snakes, what have you. Later school age and early adolescence is when social anxiety starts to emerge. So when this social pressure is key. And then even later than that would be more generalized anxiety, panic, and agoraphobia. So for a lot of other disorders, I'm taking a clear developmental history and making sure that symptoms have always been present, like for autism or ADHD. Anxiety autism can be acute. You can say, well, they were never really anxious before. But once you develop anxious symptoms, the course is often chronic without treatment. Onset is similar in girls and boys, but peripubertally, the incidence in girls goes up significantly. So I'll show you that here. So boys are the dashed line, and then girls are the solid line. So you can see sort of that age 13, 14, girls really outpace boys. And there seems to be some biologic underpinnings to this, but also sociocultural influences as well. When we think about comorbidities, anxiety disorders are most often comorbid with one another. So the CAM study, this was our largest prospective study of anxiety in kids. 36%, so more than a third of the kids met criteria for our big three: generalized separation and social anxiety disorders. Sort of uncommon. A lot of times in the DSM, we're trying to minimize redundant diagnoses. Like once you have one mood disorder, we don't like to give another mood disorder. But anxiety disorders, that's sort of the norm. And it was actually a minority that only had one disorder, social anxiety, which is a bit anomalous. Anxiety often precedes the development of other disorders. So anxiety, sort of especially untreated, can give way to depression. And substance use disorders sometimes come up in people with anxiety, sometimes as a way to try to cope. So we'll see people with social anxiety turn to alcohol or cocaine to try to be social. Anxiety can also be interwoven with other disorders. The classic example is for anxiety and ADHD. So a quarter of kids with anxiety also meet criteria for ADHD. And this is often sort of the dual diagnosis that I'm seeing in my clinic. I'll say anxiety is the most common referral reason we get. And this dual diagnosis is probably what makes treatment a little more complicated, and trying to differentiate out some of the shared symptoms, which we'll talk about in a bit. Risk factors for anxiety, family history. If family members have anxiety, you are at an increased risk. Cognitive risk factors. So if you have a style of thinking that's more inflexible, you are more likely to have problems rolling with the punches and more likely to be anxious. Behavioral inhibition. So kids who sort of withdraw when there's something novel, more likely to develop anxiety. Disrupted attachment relationships. So if you think about this, if your caregiver was not able to model soothing for you or help soothe you when you needed them, you could see how you might have an uptick in anxiety. It's hard to sort of calm your fears. Parenting style, this can be sort of go two different ways, I'll say. So parents who are sort of too laissez-faire or even bordering on neglectful, that don't the sort of like leave the kid to do everything for themselves. Kids might become anxious because they're constantly having to be hypervigilant and be aware of what they need to do. On the other side, sort of parents that are overprotective, overbearing, the classic sort of a helicopter parent. This can also worsen anxiety because kids don't learn how to face challenges. They don't learn that crest and valley on their own, right? They don't learn to anticipate and to move through anxiety and then come on the other side that's sort of taken care of for them. Similarly, family accommodation can increase your risk for anxiety as a child. So say a kid doesn't want to go to school because they're worried, and the family says, yes, no, you definitely should stay home, stay home. That's sort of reinforcing that, yes, the anxiety is bigger than you. You can't overcome that fear. And so in that way, it can increase your risk for anxiety. Substance use. So there is pretty good data now that regular cannabis use in adolescents is associated with an increased risk of anxiety. So that's definitely something I'm counseling patients on, and whether or not that's resonating is to be determined. All right. So the big joke in child psychiatry, if someone walks into clinic, what's the diagnosis? It's anxiety. It seems to be what our attendings would say. So I would say it is rare that I'm thinking anxiety, and that's probably not it. But there are a lot of conditions that can mimic anxiety and have shared symptoms. ADHD, we talked about a little bit. Isolated pure ADHD, I would think of kids as, yes, they're fidgety and distractible, but they're also impulsive and they're maybe not thinking through consequences enough. On the other side, a kid with classic anxiety would be overthinking. Yes, they're distracted and fidgeting because they're overthinking. When these two combined, often we see more of a sort of inattentive type ADHD picture. So we have kids who they want to think things through. Maybe they're even hyper focusing and thinking about things too much, but things aren't being finished. And then there's anxious fallout because of that. And then it's sort of a vicious cycle. And so when I'm trying to tease out, is there a clear ADHD? I want to know, were there ADHD symptoms? Was there sort of inattention, distractibility, fidgetiness present before the child became anxious? And in some kids, they've always been both, and I might never know. But in most kids, we'll see sort of ADHD symptoms proceeding in the preschool or early school age years, and I can sort of get that good developmental history. Depressive disorders. Depression should be episodic, and often it resolves without intervention. And so what I'm looking for when I'm ruling out depression is, was there a concrete episode where the child was sad and then it sort of went away? Whereas anxiety would have more of a chronicity, though they have a lot of shared symptoms in terms of a negative outlook, concentration, sleep problems, irritability, avoidance, and physical symptoms. OCD. So anxiety can be very ruminative and repetitive. When I'm trying to tease out, is this an obsession? Often what the concern is takes care of it itself. So intrusive thoughts in OCD are often sort of off the wall. So sometimes they're, graphic, violent, or sexual thoughts that this kid would not have usually. And other times, just the quality and character of them continuing to show up, even though they're irrational, will show that. And then sometimes the associated compulsion will reveal to me that this is OCD and not a generalized anxiety. So a good example is kids with generalized anxiety will have worries about health and safety. And so they might say, ooh, well, so-and-so in my class threw up, and I don't want to throw up because then I'll feel so terrible and I could get my family sick, and then I might miss school, and then I might fail, and that would all be terrible. And so they're catastrophizing this way, right? So I'm definitely going to wash my hands and I'm going to stay away from so-and-so. But the kid with OCD, so I had a kid who had this, they worried about keeping all their family members well, but it was this irrational way, right? They had to hand wash 3 times in a very specific pattern, or they had to start over again. And if they didn't wash their hands, their mom would get cancer. And so again, it's just sort of more ritualistic and more irrational, illogical, and with or without insight on that. Learning disorders can also often masquerade as anxiety. So kids will worry about their school performance because they're not doing well or receiving the support that they need. And so they might try to avoid school, but school avoidance is not always just related to anxiety. PTSD, I have starred this one. I would say if I am mislabeling something as anxiety and it's something else, usually it's PTSD. Sometimes kids are not ready to talk about trauma, or there's trauma that's not been remembered. But a child with particularly sort of a chronic trauma can appear very much like a generalized anxious child. So they might be irritable, have sort of a negative thinking pattern, and avoid certain things. And they might not be able to explain why, and they might have these big tantrums and outbursts. And so trauma is something I'm always screening for and trying to get collateral for as well. Bullying is similar. A kid who is being bullied might appear to have anxiety, and then you might also see sort of unresolved bullying give way to anxiety. And so always screening for bullying as well when kids are coming in anxious. Substance use. So sometimes kids, when they're withdrawing from a substance, can sort of appear anxious because they're craving that substance. And so that's something to be aware of. Substance use and anxiety can also coexist. So screening for substance use as well is something we're doing. Autism. Kids with autism can have superimposed anxiety disorders. We touched on this before, but what I'm looking for is that clear developmental history. So at its core, kids with autism have problems with social communication. And I would expect those social communication problems to occur regardless of their comfort level with who they're talking to. So they might be comfortable with less social engagement, but when they speak even to, their parents, their siblings, they might have that unusual prosody, those idiosyncratic phrases. They might seem odd regardless. This is sort of part of their neurodevelopmental picture. Whereas a kid with social anxiety, they might look odd and say the wrong thing because they're anxious in the moment, but when they're comfortable, they're not going to have those cues. Unless they're a kid with autism who's a superimposed social anxiety because of fear of rejection. All right. A number of different medical causes can mimic anxiety in kids. My party line on this is generally to say, don't follow the anxiety, follow each concern separately and use your clinical judgment. So a kid with anxiety certainly can have palpitations attributable to a tachyarrhythmia, not just the anxiety. And so do the workup that you would do based on your clinical judgment, even if there's anxiety sort of clouding the picture. Medications to worry about for anxiety, corticosteroids and stimulants. This comes up a lot for me, often because I'm treating sort of dual diagnosis ADHD anxiety kids. My other note on sort of medical conditions and anxiety is that there seems to be a clear link between chronic medical illness and anxiety and depressive illness in kids. So particularly respiratory. So kids with asthma are often anxious, kids with epilepsy, migraine. So a lot of these things, they do sort of go together. And so reinforcing care of the whole person is incredibly important as you're addressing kids with chronic illness. All right, moving on to treatment. So USPSTF recommends screening for kids 8 and up for anxiety. The two screeners I want to highlight are the SCARED and the GAD-7 in the middle. The SCARED is validated in ages 8 and up for our screening purposes. It takes a little bit longer, so I wouldn't necessarily have them in your office and then say, okay, go do this for 10 minutes, but maybe have the kids take them home. I use this because in a lot of my kids that aren't able to fully insightfully talk about their symptoms, the SCARED will get every single symptom across different symptom domains, and I can sort of see where things are showing up. And that's really helpful to me. It fleshes out my clinical interview. And then I can also compare differences between what parents and kids are picking up on and then compare and sort of discuss that. The GAD-7 is great for monitoring treatment response in older kids, so you can use that in 13 and up. It correlates well with clinical severity. So if you have a baseline in your first meeting about anxiety, you send a kid to therapy, they come back, you can sort of see how their symptoms are progressing. And then the two on the outside, the PARS, the Pediatric Anxiety Rating Scale, this I mentioned because it's in a lot of our treatment studies, so you'll see it. It's clinician administered. You wouldn't want to do it in your office. It's 50 items. It takes a little bit longer, but you'll see it in the research studies. And then there is a preschool anxiety scale for 30 months and up. It's parent report and takes 10 minutes that you could use if you had a younger kid. All right. So my overall biggest tip for evaluating anxious patients in the office is not to become anxious yourself. So easier said than done, but I would say that we as sort of people that entered caring fields, we are attuned naturally to empathically respond. And so when people are very anxious, often our response is to sort of take on that anxiety. It can often be sort of counterproductive. It's also, even if you're not able to you're able to not show that to them, if you are internalizing it, you are bringing that into your next patient. You are bringing that home. It is hard to sort of live that way. So as much as you can, when you are in the room with anxiety and you start to feel it, the best thing you can do is sort of identify it, sit with it, and try to go to a neutral space yourself, which is easier said than done. I try to do a reset between every patient, even if it's just before I, turn the door handle, just taking a breath and trying to go to a neutral emotional space, just so I'm not taking that on. Um, and then while you're in the room, it helps to just wait for a response. So ask an open-ended question, wait for a response. This creates this calm environment, and it doesn't take that long, right? So 10 seconds is not very long in your visit, but is sort of really allows for forever to let this kid reflect, think, and maybe tell you more than they would if you sort of rush through questions. You want to validate their feelings of worry, but then avoid catering to the fear behavior. So you don't want to be sort of enabling the anxiety or implying that the anxiety is bigger than them. You can offer choices whenever possible, though. So say they're anxious about getting a shot. We're accepting, the parents have consented this, you're going to get this shot, but would you like your right or left arm? Which kind of Band-Aid would you prefer? And then when you are doing physical examinations, utilizing comfort positions, really avoid putting them on their back. That's going to make them feel overwhelmed. Use truthful and concrete language. So rather than sort of minimizing or saying, oh, you won't even feel it, it's no big deal, saying it's going to feel like a pinch, it will be over quickly. I'm ordering a blood draw. I need to see how your body is doing. And so explaining to them what you're doing in sort of this concrete, definitive way without trying to sort of minimize or get around what's actually happening. Distractions are great. I think our waiting rooms do a good job with this, but sometimes when we actually get them back into the room, it feels like there's not as much to do. So sometimes just offering a fidget while you're having a difficult conversation with them or where you're talking through what you're doing can be really helpful. And then if they are coming with anxiety, it's important to assess for safety. So because of concerns for trauma, interviewing the kid alone if you can, if they're 8 and up, at least trying to do that if they're comfortable. Sometimes our anxious kids are even, it's almost like triggering for them. So if you're able, asking about trauma and then asking about suicidality. So about 9% of kids with anxiety will report suicidal ideation. We think of this as a depressive problem, but it definitely shows up in anxiety too. And then obtain collateral. A lot of our anxiety kids will be sort of, they'll want to please you. They'll want to say, everything's fine, I'm great, it's all good. But making sure you're checking in with the family and then, if needed, the school, just to get a full fleshed out picture of what's going on. And then you want to be mindful of the brain-body connection. Of course, if they're having, headaches, stomach aches every day, going to the nurse, we want to try to, get down to the bottom of, once we've ruled out any medical causes contributing, your anxiety could be influencing things here. But you don't want to minimize just because of anxiety. Treat each presenting symptom with your typical clinical judgment that you would. And then the one thing I would say that you could offer in a sort of primary care setting visit, say the kid comes in with anxiety, your initial plan, we're going to refer them to therapy, and they're like, well, what do we do between now and starting? Box breathing. So Navy SEALs use this, paramedics use it. It's quick and easy and can sort of provide a lot of physiologic calm. So the idea is we're in this fight or flight upregulated response. If we slow our breathing, we are telling our body that we are calm. So you inhale, hold for 4, exhale, hold for 4, and then just hold between in this box. And so we can model this for the kids in the office, and then that's something that they can use as a coping strategy. Now for more formal treatment. So therapy is recommended as the preferred treatment, regardless of severity, for all childhood anxiety disorders. I would say number one is rapport. So I want the kids to have good rapport with the therapist and have somebody they trust and can open up to. But technically, the modalities with the greatest evidence basis are cognitive behavior therapy and interpersonal therapy. Interpersonal therapy focuses on relationships. It's good for adolescents. CBT is probably the most adaptable to different ages, it is quite structured and protocolized, and you need a therapist who has trained in it to be able to do it. But it targets the interactions between your thoughts, feelings, and behavior, and tries to challenge and untwist our sort of automatic thinking. So say a kid has a test and their automatic thought is, I'm going to fail because I am worthless. Their feelings might be fear, shame, anxiety, and their actions might be to forego studying, try to not go to school that day, or maybe they phone it in. They do half the studying, but they're so focused on these negative feelings that they don't make it through. What we want to try to do is to challenge that thought and say, is there an alternate explanation? Maybe you're not a failure. Maybe you're, a B student and you've always done, well enough before, and maybe studying could make a difference. Any sort of neutral even thought, like I might not fail, replace that feeling with something slightly less negative and more confident, like I might be hopeful. And then your action will be to actually go through the studying process. In younger kids, there's less of this sort of metacognition. There's more focus on the behavior. So it's identifying anxious feelings in our bodies and then using techniques like the box breathing. But for the older kids, it really can get pretty advanced in how they're working through things and can be very helpful. All right, pharmacotherapy. SSRIs are king. I do hold off on pharmacotherapy for the more moderate to severe cases. And then if I have a mild case that I send them to therapy, the family's been participating and they've not had a response, then I will consider an SSRI. SSRIs have the greatest evidence base. We get about a 60% response rate. The CAM study, that was our largest prospective study, used sertraline. So often I'm doing that. You could also consider escitalopram and fluoxetine. There is evidence for paroxetine. I would say I never use Paxil in kids. It's got a lot of anticholinergic sexual side effects, sorry, and discontinuation side. It's just a whole mess. So I pretty much never use it. Fluvoxamine or Luvox has less evidence than those first three and more P450 interactions. And so it's rare that I'm going to that one, but there is evidence for it. Things to worry about: activation. So this paradoxical increase in energy when kids start it. That doesn't mean they can never take an SSRI again, but I might consider lowering the dose, stopping it, or trying a different one. There is a black box warning for suicidality. So I counsel families on this when I'm starting or switching doses. This is a long haul approach. So before I start, I'm saying it might take 1 to 2 months before we can see full benefit. And so usually I'm checking in after about 3 to 4 weeks and then increasing the dose if we've tolerated it but not seen anything. But I wouldn't consider a full trial until I've done the full 8 weeks. Unless, there's like an intolerance and I know I'm not going to be able to return to that one, but a full treatment failure would be 8 weeks. Combination CBT with SSRI seems to be better than an SSRI alone, though more research is needed. This is not as clear-cut as it is for depression. 81% of youth in CAMS responded to CBT plus sertraline, but there were some quirks of the study design that Cochrane reviews have issues with. So long story short, we would want combination therapy, but I would emphasize therapy first as first line. Other medications, SNRIs would not be considered first line for me, though duloxetine does have FDA approval. Venlafaxine or Effexor has also been studied, but discontinuation side effects are difficult, and you need to get to high doses before it's really an SNRI instead of an SSRI. So if I'm using an SNRI, I'm using duloxetine. Atomoxetine or Strattera is a selective NRI, so norepinephrine reuptake inhibitor. This could be first line in a kid that has ADHD and anxiety, so it's first line for ADHD. And in anxiety, it's almost as good as an SSRI. We get about a 50% response rate. So to reduce polypharmacy in a kid with both diagnoses, I might consider starting first with atomoxetine. Other agents, tricyclics. The evidence is not as good as SSRIs for anxiety in kids. And obviously the safety and tolerability is far worse. So these are cardiotoxic. I would avoid. Buspirone, it's really a mild, gentle medication, and the approval and evidence for adults is great. But multiple studies, we keep trying to make it happen, have failed to show benefit in kids. So this would not be considered a first-line treatment. I might use it as an augmenting agent in adolescence. So say I have a partial SSRI trial, I might add Buspar, but I'm almost never using it alone. Guanfacine has a weak evidence basis overall for anxiety, just a few underpowered studies. But I always want to be aware of it because if kids have comorbid ADHD, they might be on it. And so I might be saying, okay, we're starting guanfacine for ADHD. Let's see, with therapy, how your anxiety is doing on that, because it could be helpful. As needed medications. This is the part where I get on my soapbox. So we talked about panic attacks, right? So it takes a few minutes to reach the peak and then resolve. We talked about pharmacotherapy as sort of a second line or combination approach that really we want psychotherapy to be number one for anxiety. As needed medications can at times reinforce that you are reliant on this medication to move through and respond or get over an anxious moment instead of your coping strategies. Not all the time, but it can sort of give that impression. The other issue is if we're using them for panic, in the time it takes to find your pill, take it, and sort of digest and get benefit, 30 minutes or so, we've already passed. So the panic moment has already passed. So I really try to minimize use of as-needed medications if possible. Benzodiazepines, I would like to thank White Lotus for showing me negative effects of lorazepam because there is no evidence to support chronic use, especially in kids. Kids are much more likely than adults to become disinhibited, especially those with intellectual and developmental disabilities. I really would avoid them given the risk of dependence. The only times I'm using these are like kids who have claustrophobia and they're getting an MRI and they're getting one, or I have a kid with autism who's nonverbal, who cannot get on a plane to visit his grandma. And we tested it at home first, things like that. Hydroxyzine, this is probably the most commonly used as needed medication in anxiety. It's an antihistamine. It also has some serotonin 5-HT2A antagonism, which is proposed to be how it might work for anxiety. This is also not a first-line treatment. So it's best used second line as we await an SSRI response. So say a kid has not yet gotten into therapy, we're starting an SSRI because symptoms are moderate to severe, we're awaiting that response and they're having panic attacks, I might give some hydroxyzine to alleviate that anxiety just short term as we wait for the SSRI to work and to, get a kid to school, for example. There's no indication for it as monotherapy for use chronically or for insomnia, though. Propranolol is sort of interesting. It can target the physical symptoms of anxiety, so shakiness or palpitations. Pretty much all professional golfers apparently take it just to sort of calm down, like when they're putting and things like that. I would consider that in ages 12 and up if you had a situational or performance anxiety. I had a kid who played the trumpet and he would shake and sweat and get really nervous. And so propranolol would help him for performances and things like that. And here are references.